Hi, I'm Monique Gaudet, and this is my final presentation for the class Maternal and Child Health. The case study that I chose to focus on was working moms feel pressure to breastfeed, but struggle getting the time and support to make it work. We'll be going through 7 phases for this presentation. First, we'll cover the problem statement. Second, we'll talk about proposed interventions. Third, we'll discuss the proposed evaluation. Fourth, we'll list the potential challenges and barriers we may experience while trying to implement the interventions. And fifth, I'll present the logic model, which will clearly illustrate the project as a whole. And the final slides will be a list of references. Now for the problem statement. There's convincing evidence that breastfeeding provides substantial health benefits for both mothers and babies, but not enough young mothers adopt the practice due to lack of knowledge about breastfeeding, lactation problems, poor family and social adoption support, lack of support when returning to work. So when looking at this problem within a public health context, we would consider that even though the current prevailing public opinion in the U.S. actually supports women as the most healthy option for both mother and child, there's a limited amount of actual support and infrastructure for it in our society. So within the contributing factors of social determinants of health, the 3 health indicators that help describe the issue include education level, socioeconomic standing, and access to appropriate preconception, prenatal, and interconception health care. So now we'll describe the issue by applying the social ecological model to our case study. So we'll be looking at the individual, interpersonal, organizational, and community levels. So at the individual level, we consider one helping factor to be knowledge, and that the mother is aware of the full benefits of breastfeeding that are provided to herself and her child. One factor that hinders breastfeeding adoption is a negative attitude. So if the mother doesn't like the experience or feels uncomfortable during breastfeeding, she's much less likely to breastfeed. On the interpersonal level, one factor that helps encourage the decision to breastfeed is peer support. One study showed that the more people that the breastfeeding mother had contact with who supported breastfeeding, the more likely the mothers were to be satisfied with breastfeeding. One hindrance to breastfeeding on the interpersonal level can be family. A lack of support and knowledge on the subject within the family and partner can be a significant barrier to breastfeeding. Also, conflicts with household duties and other children to care for can be large factors. On the organizational level, various organizations such as the World Health Organization and La Leche League support breastfeeding mothers through support groups, education, and mentoring. A major barrier on the organizational level are workplaces. A new mother's place of employment may not be as supportive of her decision to breastfeed, so that might lead to a lack of place to pump, or if the pumping takes longer than the allotted federally mandated 15-minute break, the mother's wages can be docked. On a community level, relationships among community organizations and the presence of breastfeeding support in hospitals has greatly increased the rate of breastfeeding. One community level barrier to breastfeeding is actually public opinion, like we talked about before. Women might have the potential to be ashamed if they breastfeed in public, and ambivalent attitudes toward breastfeeding are part of the problem. So they've really made laws necessary, which actually brings us to our next level, the policy level. All states now allow breastfeeding in the public, although laws vary by region, and it's really up to the states themselves as to what they allow. The biggest barrier to breastfeeding is a lack of law enforcement among the states. And also, once those laws are enforced, there's a lack of, governments have not a lot of sense of what the reasonable penalty should be for a violation of those rights. So we have described the issue and listed out a few helps and hindrances on each of the social ecological levels. So now for our proposed interventions. Let's dive right in. Our first intervention is taken from the County Health Rankings website and is a breastfeeding promotion program. The program will provide education and information about breastfeeding to women throughout their pre- and postnatal care, as well as offering lactation counseling services. The following resources are needed to implement this intervention. And actually, the other two interventions have a lot of this in common as well. Subject matter experts will be needed for every program. They will create print and web-based educational materials. And also for every program, a graphic designer is going to be needed to assemble that information in a clear, easy-to-read format. For this intervention, healthcare workers that specialize in lactation counseling services will be needed throughout the intervention. In each intervention also, program staff will be needed and in different capacities. In this one, they'll be educating healthcare professionals about the initiative and its goals, and they'll also actively work to recruit new intervention sites and establish support groups for nursing mothers. In this intervention, counseling personnel will provide support and volunteer training. So this intervention is targeted primarily towards mothers and mothers-to-be with the goal of raising breastfeeding, initial breastfeeding attempts, rates of breastfeeding adoption, and rates of women who exclusively choose to breastfeed until their child is 6 months of age. Our second intervention is an in-hospital breastfeeding support program. This intervention includes all maternity care practices that support breastfeeding. These also include working with the hospital and developing a written breastfeeding policy for them, and training hospital staff on these what's in the policy, as well as providing educational materials and training them on best practices. Again, for assets, it's similar to intervention 1, where you need the subject matter experts, the graphic designer, the program staff, and you'll be leaving behind educational materials for that. Our third intervention is a community health worker program. So this intervention would be a coordinated effort to provide outreach, education, referrals, and follow-up, as well as case management, advocacy, and home visiting services, one-on-one, to pregnant women and new mothers. Again, the assets for this would be similar to the other two: program staff, graphic designer for educational materials. This one, the unique asset is the community health workers. They will need to be trained, and they would be needed to distribute the educational materials and also provide outreach, case management, and other services. Let's see. So each of these interventions relate to the problem statement and the ecological model by using different approaches to the problem statement and resources to work toward the ultimate goal of increasing the prevalence of women who exclusively breastfeed until their child is 6 months of age. And how are we going to know if these proposed interventions worked or were successful? So for the first intervention, the aim is to increase the initial breastfeeding rate through education. So intervention staff would collect data on how many clinical sites were offering this education to their patients, and data would be collected via questionnaire sent to the healthcare providers. For the second intervention, one aspect of this is to create and disseminate a written breastfeeding policy for hospital and staff. So to determine if providers were following the protocol in the policy, intervention workers could visit the hospital and spot check and survey staff members to see whether or not they've been briefed on the existence of the policy and whether they know the contents of the manual. Let's see. Data would be collected by intervention staff, observation. For the third intervention, one process measure to evaluate the intervention would be to analyze community health worker outreach frequency. And data for that would be collected via questionnaire sent to community health workers and could include data from EMRs where available. So how would we measure success? Success, very simply, would be measured by breastfeeding adoption rates and if they increased after exposure to one or more interventions. Next is potential challenges and barriers. So the barriers to breastfeeding initiation and adoption are multiple. Among women who did not initiate breastfeeding, 48% said that they didn't like breastfeeding, and 30% said they needed to return to work or school. Others cited personal preferences, having an unsupportive partner, feeling embarrassed, and concerns about pain. So let's see, the collaborative points, virtually every sector of public health could be brought in to collaborate, from health educators to epidemiologists, researchers, policy specialists, program manager, and public health nurses. They could all work together and on their own to fill unique roles in coming up with a solution. Finally, we move on to our logic model, which really is a one-page model that just concisely condenses each aspect of our program plan that we discussed. We have intervention 1 and the resources, what we would do for that intervention, who we're reaching, the short-term results, the medium-term results, and that's the same for all three of those. And then our ultimate impact is increasing the prevalence of women who exclusively breastfeed until their child is 6 months of age. And that does it. These are my resources. Thank you so much for listening, and I hope you have a wonderful day.